From Imperial College London, welcome to this special lecture vodcast.
Well, good afternoon everyone, and welcome to this annual lecture kindly sponsored by GE Healthcare. Imperial and GE of course collaborate in a number of ways, so this evening is a nice opportunity to celebrate what we're achieving together. Today we're looking at a large, extremely important topic: how medical technology can help to tackle Africa's diverse health challenges. And thankfully, we have two of the most knowledgeable and experienced figures here to unravel those issues for us. Both have in many ways dedicated their careers to understanding and controlling infectious diseases that are blighting millions of people worldwide, and of course which are taking a particular toll in Africa at this time. Our first speaker is Professor Michel Kazatchkine, who's thrown enormous energy into fighting HIV and AIDS over the last 20 years, both as a physician, a researcher, and as a policymaker. His involvement came about almost by accident when in 1983 he treated a recently returned couple from Africa who was suffering from an unexplained immunodeficiency syndrome. And that led him, of course, into open an AIDS clinic in 1985, and then in 1988 to found the first night clinic for HIV patients in Paris, offering confidential treatment outside normal working hours. Since then, he's been director of the French National Agency for Research on AIDS and France's ambassador for HIV/AIDS and communicable diseases. And this, of course, is in addition to all his other demanding roles, such as Professor of Immunology at the Université René Descartes and Head of Immunology at the Georges Pompidou Hospital. Earlier this year, he was elected Executive Director of the Global Fund to Fight AIDS, Tuberculosis and Malaria, having previously been Vice Chair of that organisation. And he'll be speaking today about the medical technologies to fight these three diseases. Our second speaker is Sir Roy Anderson, a very familiar face at Imperial. He studied here, spent most of his time here, nipped off to Oxford for a little while but quickly came back, and of course he's going to be our next rector. He's a very distinguished epidemiologist, leading authority on the spread and control of infectious diseases, including tropical parasitic infections, BSE, CJD, HIV, influenza, and foot and mouth disease. He recently completed a 3-year secondment from Imperial to be the Chief Scientific Advisor to the Ministry of Defence, where he was there to lead the Department of Science, Innovation and Technology. At Imperial, he's Professor of Infectious Disease Epidemiology, and that's a position he's held since he came back to Imperial in 2000. He's sat on many committees advising on public health and disease control, including the World Health Organization and UNAIDS. He also chairs the Gates Schistosomiasis Control Initiative, based here at Imperial, which is tackling this tropical disease that causes chronic ill health in over 200 million people across sub-Saharan Africa. And this initiative, of course, was recognized earlier this month by the Queen's Award for Industry, because it's just been such a prominent event. Sir Roy will be talking this evening about schistosomiasis and other neglected tropical diseases in Africa, where medical interventions, of course, can make such a difference. I think we're in for a very uplifting evening today, because our two speakers are both people who look at how they can do things and how they can get things moving as opposed to talking about it and being deterred by difficulties. And I believe both of them made a real difference around the world to people's lives. I'd like to thank GE again for their support for this annual lecture, and both speakers, of course, for coming along and sharing their time and expertise. So first of all, Michael will speak, and then Roy, and then we'll have a Q&A. Michael.
Thank you very much, Sir Richard. Good evening, everyone. Dear colleagues, it's a pleasure for me to be here, back at Imperial. When reflecting on medical technology and achieving the MDGs in Africa, I will, of course, focus on MDG 6, because we at the Global Fund are focused on combating HIV/AIDS, malaria and tuberculosis. But as you know, tackling AIDS, TB and malaria impacts directly also on other MDGs, such as MDGs 4 and 5, reduce child mortality and improve maternal health. And there is a health dimension, in fact, to each of the 8 MDGs, and we've learned in the last few years how all development efforts and how all of these MDGs are in fact interdependent. Now, the first point I'd like to make is that if I focus on expanding AIDS treatment in Africa and in the developing world, we've made tremendous progress in the last 5 years. And this has happened somehow in the absence of any significant technological innovation, except, of course, for the starting major progress that was the availability of potent antiretroviral drug combinations back in 1996. So what we're looking at is that now there is a real possibility of stemming the death toll of AIDS in Africa and in the developing world. I'll give you some numbers in a few minutes. But yet, when I look back at the last 5 years of efforts and expansion of antiretroviral treatment, it appears that technological barriers have been and remain a relatively small or negligible compared to the limitations posed by actually capacity-related issues or implementation-related issues. This is not to say that medical technological innovation is not needed, and I'll come back to that later. I think technological innovation for delivery is somehow a neglected area and remains far insufficient, although obviously it could improve significantly the rate of scale-up of both prevention and treatment, as well as the quality of care. So let me look back at what I believe are the key factors that have moved us to reach large scale-up in HIV treatment in Africa in the last 6 years or so. First, I believe a major change in the way we look at health and development, a change in paradigm about the relationship between health and development. And I'll come back to that in a second. And as a consequence of that, an unprecedented mobilization of the political world and the mobilization of large, unprecedented resources for AIDS and global health in general, the mobilization of the civil society, access to cheaper drugs and commodities, the documentation of the feasibility and effectiveness of large-scale treatment interventions in resource-poor settings. Back in 2001 or 2002, a number of people were still skeptical about whether scaling up to in resource-poor settings would be feasible. And that is what we've learned from a new area of science which I know is represented at Imperial. And Roy, I guess you're one of the leaders there, which I call operational research. And I'm sure that this part of science will soon have its own meetings, publications, and journals. Let me go back to this change in paradigm. For many years, people have been thinking that one needs to develop, to build roads, to educate, to contribute to economic growth, in order then for health to come as a sort of reward or consequence of development. That was the philosophy of the, let's say, of the 70s and certainly, but also of the 80s and early 90s. However, in the late 90s and early 2000s, the AIDS crisis has told us that, in fact, if you do not address health as a priority, then you actually cannot develop. And the paradigm has turned around so that the health sector, which has long been considered in development as a sort of non-profitable source of expenditure, is now understood as a necessary and even as a priority investment for development. And the consequence of that, as I said earlier, is an unprecedented increase in resources. What you see on this slide is resources, estimated total annual resources available for AIDS that were around $600 million in 1996, and that were estimated to be slightly over $10 billion this year, 2007. And availability of those resources came with a large expanding access to antiretroviral treatment, from slightly over 200,000 people receiving antiretroviral therapy in the developing world, of which 150,000 were in Brazil in 2002, to a figure of 3 million on ART right now at the end of 2007. We've also learned that, contrary to some of the predictions we heard of a few years ago, treatment is not only feasible but as effective in resource-poor settings as it is, as we learned it to be in the north. This slide, taken from the ARC-Link cohort, shows that at 6 months of treatment, the mean percentage of individuals coming to what we call undetectable viral load with antiretroviral therapy in South Africa is similar to what we see in the north here in the Swiss cohort. And we're now seeing impact on morbidity, and that was documented, for example, among Kenya tea planters, and impact on mortality. This is a slide showing a very significant decline in mortality in the workplace in one of the largest companies in Malawi a year and a half after rolling out antiretroviral treatment through a Global Fund supported program. So my point is, these successes have taken place somehow outside the context of any new major technical innovation in between the introduction of antiretroviral therapy and now. And if I look at the challenges that we face in the coming short-term, mid-term 3 years here, and think about what are the challenges we will have to respond to, these are challenges of having even more additional resources, to have sustainability in the resource flow. We still have challenges of drug costs, particularly with the cost of what we call second-line antiretroviral therapy. We have the challenge, very much linked to sustainability of services, of introducing health protection, social security, which I think for health systems in the developing world is the key to sustainable access to health care. We have major challenges, I'll come back to that, with delivery with health systems. We have challenges with the knowledge of serological status, and we have some other challenges that I'll not go into. But again, if you look at this slide, certainly there is room for technological innovation, for example, with rapid tests to learn more and more rapidly about one's serological status. But most of these challenges, again, are somehow beyond the scope or outside the scope of technological innovation. Health systems is the major bottleneck. There's a lot of talk these days about health systems. There are ideological battles between those who feel that we should go on with what we call vertical funding, disease-targeted funding, funding for AIDS, TB, malaria, versus those who think, let's go back to horizontal funding, that is, first build the health systems, and then that will provide the appropriate platform for addressing the diseases. Of course, that's a false dichotomy. First, we're not discovering, of course, the lack or the poor state of health systems in Africa now. AIDS has just been a revealing factor as we try and scale up treatment of the fact that in terms of personnel, medicines, physical infrastructure, none of these health systems have ever been adequate in most developing countries to address even the basic health care needs of the population, so let alone of a new major epidemic. What we have learned is that one of the ways to bypass the bottlenecks of poor health systems and insufficient workforce is to use community care and expand treatment through community. There is now a very significant experience in Africa and elsewhere in the developing world on the fact that adherence, support to treatment, and a number of prevention efforts are most effectively delivered by peers in community settings. And as we have standardized, as WHO has helped us in particular, standardized treatment strategies through simple regimens, we have learned what we call task shifting. That is, in fact, having non-medical people trained for a few weeks and then actually delivering the treatment to patients, and then learning of the early warning signs that should then, in case they're encountered, have the treating person address the patient to a doctor or one of the few available doctors. I said earlier that I think the debate between horizontal and vertical funding is a false dichotomy, because in fact we have now significant evidence that bringing in heavy money on AIDS or TB, on malaria, is in fact positively impacting, has positive spillovers for health systems. For example, in Haiti, in Paul Farmer's program in Cange, in Haiti, scale-up of AIDS and TB treatment has led to, indirectly, to improving delivery of clean water, sanitation, and thus of vaccinations, improving a number of primary healthcare indicators, increasing by fourfold in that region prenatal visits, and improved staff morale and community participation. The strongest, the most evident example to me of the disconnect somehow between medical technology and implementation bottlenecks is prevention of mother-to-child transmission of HIV, where major progress has been made. We now have the drugs that in breastfeeding women in sub-Saharan Africa have decreased the residual risk of transmitting the virus to less than 4% in the latest figures. And yet, as you can see on the slide, implementation of PMTCT services, that is the percent coverage of those services in various countries, is somewhere around 12% as a mean, ranging, as you see on this slide, from between 3-4% to 34%. So one may think that we are in fact facing a two-tiered standard here, with a highly technological world delivering health in the north, and another standard of delivery of care in the south. And I'm very much opposed to the, I guess as many of you, to the two-tier standards that many of us as scientists discussed in research. Because for a physician, they basically question the universality of care. And they define standards of care from a relativist standpoint based on economic rationale. And this is something that would bring the ethical debate into politics, or into a new subsection of politics that you would allow me to call biopolitics. But AIDS has also actually taught us something very different, is that it's the research in the South and the innovation in the South that is now feeding progress in the North, paradoxically. Because we did have to standardize antiretroviral regimens in the South and have one or two very simple regimens and no more, the first clinical trials and then the first expanded use of single once-a-day therapy in a one pill or two pills once-a-day regimen, these trials were performed in the South. And this then led to the one-pill treatment or once-a-day treatment in the North. 2 years later, this slide shows that back in 1996, the original regimen of Indinavir 3T/CD4T included 10, the patients had to take pills 10 times a day, and now the once-a-day regimen of tenofovir, FTC, and efavirenz became available last year, 2006. 2.5 years after that type of regimen actually came into function somehow in the developing world. So I see this very interesting interchange here. In the North, we have focused on individually tailored for the patient combination therapies. We have more than over 20 drugs available. We have sophisticated virologic, immunologic, and resistant testing. And we badly need fixed-dose combinations to make the treatment simpler. In the South, we have started with standardized HIV treatment with fixed-dose combinations. We have gone to simplified clinical monitoring because we did not have the sophistication. And we now need the innovation to bring increased CD4 and viral load testing in affordable and simply accessible ways. So these are opportunities I see for medical technology in order to reach MDG 6 in Africa. Expand rapid testing, further simplify treatment, and bridging the major gap in laboratory monitoring of treatment that requires progress in technology. I've been mostly talking about AIDS, and in my just 2 last minutes, let me focus also on malaria. I can't have a presentation without a propaganda slide on the Global Fund. So these are the latest figures of the results of Global Fund supported programs, which are estimated to save 3,000 lives a day, 100,000 lives per month. Now supporting 1.4 million people in the developing world on antiretroviral treatment, having treated 3.3 million people for TB, and having distributed 46 million impregnated bed nets to prevent malaria. And malaria is certainly an area where in recent years technological innovation, and particularly the availability of long-lasting impregnated bed nets, together with the availability of potent drug therapy combinations, the ACTs, artemisinin-based combination therapy, are having a tremendous impact. This shows the decrease in bed occupation in a hospital in rural Rwanda, and now there are areas in Kenya, Rwanda, some Mozambique, in Zanzibar, where the incidence of severe malaria and of mortality among children below 5 has decreased in the last 2 years by a factor by 60 to 85%. Very impressive indeed. So the points I've been making are as follows. First, some sort of paradox, perhaps, that large scale-up in AIDS treatment has occurred in the last 5 years, even without any major technological innovation that would have occurred since the availability of triple combination antiretroviral therapy. Then an observation that it is innovation driven by the epidemic in the south that is now somehow benefiting patients in the north, something that we're not used to, and I hope we'll be used to more and more through the introduction of fixed-dose combinations. And then that there is a need for increased innovation to increase that rate of scale-up of both prevention and treatment and to improve quality of care. And if the ultimate public good that technological innovation can bring to populations in the developing world is a vaccine, I've listed here 4 of the vaccines that are badly needed for the developing world. I guess I could add an anti-schisto vaccine as well to the list. One of these vaccines is available at HPV. Malaria may be available by 2011, 2013. But the lesson from HPV is that that vaccine has been developed for the developed world and is available in the developed world and has not been developed for the developing world where it is badly needed, particularly in HIV-infected populations. So let's be careful in the future when we think about medical technology that we think about the developing world and do not produce vaccines that then, as they become available, are in fact not accessible to those who need it worldwide. Thank you. Roy, again, the floor is yours.
Well, first, it's a great privilege to be here to give this lecture tonight, and very especially because it's following Michel, who I've known for some time, given our shared interest in HIV, mine from a different end to Michel's. What I want to do today is to talk about control of morbidity and mortality in neglected tropical diseases, and although I'm chairman of the SCI board, in essence I'm speaking on behalf of the 3 key scientists, Joanne Webster, who runs the scientific research part of the SCI, Alan Fenwick, whose brainchild it was and whose drive and energy has taken this forward in terms of raising money, convincing donors, and Artemis, who keeps us all honest as the senior statistician in the sense of making sure that we don't claim too much success and so forth. What I want to very quickly do is go through burden of disease, NTDs, and I'm going to move very quickly in the first part of this talk, and then talk about where the Schistosomiasis Control Initiative is, and in particular I want to talk about some technology and research results from the staff. And then I'm going to end very quickly with some personal thoughts about HIV treatment in Africa, very much because it involves a new technology which I think is neglected, related to patient adherence, and it's something I've been involved in with John Urquhart from San Diego in America. What are the neglected tropical diseases? Well, they're a very odd assortment. They don't fit together. There's protozoan infections, there's bacterial infections, but the ones I'm going to concentrate on today are the helminth infections. These are big metazoans, complex genomes, very interesting biologies, hugely evolved species, with tons of very neat little methods for evolving the human, or evading the human immune system. So they're clever beasts, much cleverer than even malaria, and certainly much cleverer than HIV. because they've got multiple arms of intervening into the human immune system and shifting its attention. How dominant are they? How important are they? Well, an estimated 500 million people in Africa are infected with one or more of these. Multiple infections are common. And the most staggering thing, and this is where my theme very much fits Michel's earlier, is that current technologies, except in a few areas, are very effective at dealing with these problems. And the issue is logistics and supply and getting these drugs to the people in poor regions of Africa. But I am going to comment on one or two technologies that are emerging that are beginning to help. So we have safe and effective drugs. Now, if we look at the burden of disease in Africa as of 2006, these statistics you always have to take with a little bit of caution because they're quite crude in some countries. The key bit, the neglected tropical diseases, DALIs, for those of you not familiar with this jargon, dreadful jargon, it's a way of estimating via the World Bank's economists, health economists' approach to morbidity and mortality induced by a particular cause. And it's disability, life, years lost, and so forth. Neglected tropical diseases have a very important component, and if we look throughout this pie chart, infectious diseases dominate totally today in Africa, with the big three, malaria, tuberculosis, and AIDS, hugely important, but the neglected ones, very important too. Now, the Millenium Goals, Michel's already dealt with this, under 6. Where do NTDs fall? They fall unmentioned in other diseases, but I do share some, as it were, sympathy, but tuberculosis wasn't mentioned either. But anyway, they are down the bottom of the list of priorities here at the moment, but rising in donors' minds as something which is almost like low-hanging fruit. It's something you can deal with quickly, if you have the will. Now, what is SCI? Richard's already mentioned that this is a control initiative which was established by very generous funding from Bill and Melinda Gates Foundation. Its objective was to work dominantly in Africa and to control or reduce the morbidity due to schistosomiasis and intestinal worms, prove or develop the ability of countries to implement programs if they had resources, so it's a proof of concept. And most importantly of all, amongst the people, if they feel better post-treatment, to create a local demand for these treatments. The strategy was to use one particular drug, praziquantel, very effective drug indeed, annually or over 2 years, between the ages of 16 and 14. And this will mean that these children are unlikely to suffer extreme morbidity events. Unlikely, I say, because it's still possible later in life, but they're most unlikely to do so if treatment is successful. Then, of course, the concept's expanded. Well, if you're treating, given the importance of logistics, if you're treating for one disease, why not try and treat for many? And albendazole, which is another very effective drug that treats intestinal helminths, and this will improve nutritional, educational attainment, and so on. And I'll come to that in a little bit. So that is the strategy for SCI. Now, just to comment on these soil-transmitted helminths, because I started my life with a very generous grant from the Rockefeller Foundation to work in India and Burma on these, and they're very unfashionable because they're big worms, and the reason probably is related to this. This is ascaris that that poor child had. They are very big worms, very unpleasant-looking beasts. They absorb a lot of nutritional components from the gut of these children, and they cause considerable stunting in growth for them, and they're easily treatable. And here's an example. The colour patterns on this slide don't pick this up too much, but here's a child. This is an illustration of a single patient where treatment for 2 days with an effective drug, and that growth profile of that child, that's weight for height profile, takes a real spurt and returns back to the normal profile of children in that area. So these drugs can have quite dramatic impacts on children that are infected with these worms. Now, what are the schistosomes? They're really a totally fascinating organism in terms of their biology. The male and female live in permanent, as it were, harmony, one enwrapping the other. And there are 5 species, 2 dominant in Africa, of particular importance, and they're endemic in 70 tropical countries. Biologists really, I remember as a student, get totally fascinated by these beasts because of the complexity of their life cycle and the size of the worms. They're chronic and debilitating. About 200 million people infected, 120 million with symptoms, and then perhaps 280 deaths annually. And this is an illustration of a patient with acute morbidity due to Bilharzia schistosomiasis disease. This is the complexity of the life cycle. We have a lot of biology here where worm in adult releases eggs into the water, little stage hatches, a myristidium infects snails, which is an intermediate host. Asexual magnification of the life cycle releases another stage, a small water free-swimming cercariae, and that penetrates human skin. Very interesting life cycle in biological details with sexual and asexual phases, partitioning of habitats for those reproductive efforts. Inside the human host, very complex here, got a lot of evolution and immunology going on. Parasite has evolved methods of combating the human immune system. And when you start to add chemotherapy, then clearly you've got patient adherence, the pharmacokinetics and dynamics, and overall, before you get the production of eggs for transmission. We have very good mathematical frameworks for the study of these organisms, their dynamics and the impact. So as engineers do, and physicists do, and astronomers do, we can simulate the effect of an intervention program before we go to the costly bit, which is actually doing it. So it gives us good scientific insights into what might work. What we can't simulate at the moment is the horrible complexity of population genetics, but that's a matter of time. Now this is one of them, Schistosoma hematobium. These are 3 children. This particular species of the beast infects the bladder, and of course children gets damage to the bladder wall, and there's blood in the urine, and it's a very simple and easy diagnostic test. And the amount of blood in the urine reflects in part, not in a linear way, but in a non-linear way, the severity of infection. This is a typical pattern in a poor community of the burden of infection over age. This is hematobium from Tanzania. Dominant burden of diseases in young children, and then adults have a lower burden of infection. The reasons for this have been much dwelled on, and in fact, if one's honest, the answer is not totally settled. It's a combination of exposure, that's water contact, and indeed immunology, the build-up of acquired immunity. The grant I got originally from the Rockefeller Foundation was given by Ken Warren, whose name may be familiar to some of you, an immunologist, who, even as an immunologist, said, well, I believe that much of this is exposure, not immunology, and he was significantly right. The levels of infection are monitored by intensity, which is the worm load, or an indirect measure of it, and the prevalence, that's the proportion infected. WHO and international agencies tend to focus on prevalence because it's a simple thing to measure, proportion infected. I put this slide up just to show that that's a very unwise move, because there's a highly nonlinear relationship between the mean and the proportion infected, because the underlying probability density distribution is negative binomial. So when you start to control with chemotherapy, you push this way, and if you're only measuring prevalence, for huge changes in intensity, you have very small changes in prevalence. So you can be led falsely to believe that your chemotherapy is not having much impact. And this just reflects a rather trivial point. It's important to understand dynamics and statistical issues if you're to implement control and interpret control measures wisely and correctly. From models, of course, we know timescale dynamics of these systems, where from the equilibrium intensity of infection, you treat with a round of chemotherapy a certain proportion of children. Then a second round of chemotherapy, you have bounce back always, because reinfection occurs. And the more of these rounds, the lower you get this, the longer the bounce back time, and one understands that very well. There's a lovely, elegant little bit of theory here, which tells you, almost by the back of an envelope calculation, what the bounce back time is in reflection on the generation time of the parasite, which is in part measured by life expectancy. The longer that life expectancy, the slower the bounce back time. And schistosomes have a long life expectancy. Now, the real issue with mass treatment programs, just as in HIV, is If you apply an intense selective pressure by drugs, will you select very quickly for resistant genotypes? If you look at the history of the treatment of infectious diseases, the history is depressing. In every single case, the intensity of selection, when drug use has got high, resistant organisms have emerged, whether they're viruses, bacteria, or protozoa. Helminths are a more complex genome, and the story at the moment is positive, but the importance is that if it emerges, it will be sigmoid for very good population genetic reasons, and there will be a very long silent phase where this is growing exponentially, but it starts from a very, very low frequency. And this silent phase for something like schistosomes could be many decades. So just because you haven't selected heavily or seen the emergence of resistant phenotypes or genotypes in the first 5 to 10 years does not say anything. It tells you the dynamics of these systems you've got to monitor and carefully watch for a long period of time. Now, at the moment, successes achieved by this team are quite extraordinary, treating here in 7 countries, and of course, I know Alan Fennick and Joanne and others in the group would like to cover this continent in blue, as it were, and treat all over, and it's a matter of raising money, and I sincerely hope we can do that in the future. Michel mentioned the number of treatments that his organisation has achieved, so let us brag here about SCI. We've achieved 43 million treatments of children, so that's not too bad, given that our resource is not N billion, it's somewhat less, as a set of very dedicated young staff who've been involved in training people. In the back of any mass treatment program, you must select cohorts of children to monitor over time, and these are some of those cohorts from different countries. These cohorts have to be of significant size. This is a very costly exercise and time-consuming to monitor them, but you've got to do it. The monitoring is complex, and there are very many arms to this. There's ultrasound, height, weight, CATO-CATS, which is measuring burden, eggs, hemoglobin, all sorts of things. So there's quite a set of skills that are required here. Apart from the ultrasound, most of these are low-cost technologies. The ultrasound is to look at liver damage. These are low-cost technologies that can be taught very quickly to nursing staff and physicians within the country setting. In a school setting, can even be taught to school teachers in that setting. And these are the results from one particular country. This is looking at no infection, light, medium, and heavy. And you can see by rounds of treatment, virtually eliminated in this particular study position or spatial location, the heavy infection burden, which is what causes the morbidity in these children. So, dramatic success. I now want to very quickly turn to some new technologies and the work of Joanne Webster's group, because I really do believe that this is making a very significant contribution to this, and this is related to the new technologies. I won't have time to go into the detail here, so I'm going to mention 4 topics that I think are important. The first is a paper that's published on the first microsatellite molecular markers for these dominant species. And if you take the worms from the field, the eggs from humans, and then passage them through laboratory rodents, you tend to change the genetics of these organisms, and therefore you don't get an accurate picture of genetic change that's occurring in the field. And what Joanne and colleagues did was to work out a way of looking at genetic change using field isolates without passage. And I think that's a very important step forward, and this paper has made a very significant contribution towards this project. The second one is to monitor genetic change. What happens when you intensively apply praziquantel in a community? And by using sequence information, microsatellite information, then you can do a lot of things. And here's one. When you treat a group of children, and you come back 3 to 6 months later, sometimes you find infection still present. And you think, oh my God, is that because there's a resistant worm, or I've selected for resistant types, or is it because of reinfection? And these methods can be used to provide robust answers to those questions. It's more commonly, or if not always, reinfection as opposed to heavy intensity selection at the moment, or failure of treatment. Now, as in all treatment programs, whether viruses, bacteria, or whatever, if you apply a very heavy selective pressure, you reduce, in the first instance, genetic diversity. Now, for viruses, the bounce-back time for HIV is so rapid that that diversity explodes very, very quickly. For these beasts, much more slow dynamics life cycle, then you are reducing genetic diversity, and it's important to monitor this, because what you don't want in this reduced genetic diversity is evolution of organisms that are drug-resistant to praziquantel. And then lastly, from Joanne Webster's group, and this is unpublished, and I'm grateful to them for permission to use it. This is a japonicum, which is in Southeast Asia and China, very, very important parasite there. But it's unusual in the sense that it has an even more complex life cycle, because the worm can go through many different mammalian hosts, including dogs and water buffalo. And you can imagine in these rice-growing areas, water buffalo and snails, a lot of contact. And once in infectious disease epidemiology, once you have animal reservoirs, your problem of control in humans gets huge. Now, what genetic techniques from Joanne's group have done is to be able to think and pose questions about taking the parasites in the humans, taking them in dogs and water buffalo and so on, and taking them from snails. Which of these hosts are the most important in sustaining transmission in the human community? And that is beginning to produce some very interesting results. And it may be, and I leave the experts to talk about this, because this is unpublished as yet, that one particular mammalian species, the dog, is rather important. So those are technologies based on molecular genetics and sequence information. Now, just finally, to quickly go through integrating this, if you're giving one drug, the logistics of delivering this to a poor community, then why not? And this is the idea of Alan Fenwick, David Molyneux, Peter Hotez in the United States, and others in WHO, Lorenzo Savioli, to actually produce a rapid impact package combining drugs for the treatment of both filarial worms, intestinal worms, and the schistosomes, and indeed a bacterial infection. And this rapid impact package, we don't have the privilege of one drug yet. Very complex pharmacodynamics and genetics here. Be wonderful if one could have one pill. It really would. But let's say you can give all these pills in a school setting, then what sort of impact can you have? And that's the venture that people are on at the moment. And I want to just mention the effect of the pharmaceutical industry. I'm not an advert for them, but it is very, very encouraging to see that the industry has made very significant donations of these drugs for the developing poor countries, or provided the drugs at very, very, very low cost, much, much, much lower cost than the developed world. And therefore, putting this package together, the drug purchase becomes a very small element of this approach. And if you look at this, and I shouldn't stress this, given Michel's here, the cost of treating HIV/AIDS, the value here is about 350 plus. I know that it can be done for about 150, 180 per annum in some countries, given fair wind. But just have a look at this little rapid impact package that has so much benefit to these children in terms of their growth and educational attainment. It is essentially 50 cents per child per annum, and that's quite an extraordinary impact for a very small amount of money. What one would like to do, of course, and this is Alan Fenwick and David Molyneux, Peter Hotez and Lorenzo's mission, is to raise just over £1.5 billion so one could treat every child in Africa. Now, just to summarize that, this is, in my view, a low-hanging fruit. The pharmaceutical industry is on side and being very generous in its donations. These diseases are diseases of poverty. There's something that we can do something about for a very, very low cost, 50 cents per person treated per year. And the current and future objectives of combining a bit of technology, high technology and good research, with the logistics of getting these packages organized into children. Now, the last thing, and I just wanted to briefly comment on this, adherence. All of you in this room belong roughly to one of three classes, and I won't ask you to put your hands up. A subset of you are compulsive obsessives. So if you're told to take a pill in a particular course, you will do so exactly on time, etc. At the other end of the spectrum, there's a fraction of you that are totally and utterly chaotic in your lives. Not all parts of your lives, I'm sure, but in essence, you will never take it right and you will never take the full course. And then the majority are somewhere scattered in between. The big worry about HIV treatment in Africa, of course, was patient adherence. And I just want to mention a technology that I think is vastly underused and the cost is tumbling, which could be of great help. When you compare adherence in North America and Africa, and this is a paper, I haven't put the authors on here, it's a bit naughty, but let me, because I was going to criticize the paper, so I always believe in anonymity then. Essentially, this paper gives a very misleading impression because it says adherence in Africa is much better or as good as adherence in other parts of the world. Adherence is a very, very complicated problem. So somebody can say, I take all my pills per day, but the interval between the pill take, which should be 12 hours, could be 6 hours. And that means there's very dangerous periods of low drug concentration. This is what happens when you fail to take a pill. The troughs in the concentration of the drug in the blood drops below a critical level, and that permits the evolution and selection of drug-resistant strains of the virus. And remember, the virus is turning over on a generation time of hours to days. So every mutation across the whole genome occurs every day. Evolution of resistance, this was Wellcome's and then Glaxo-Wellcome's first drug, a wonderful advance actually in this area, the first antiviral it was based on, zidovudine. But essentially you can have a very small number of mutations, here 5 in particular locations, and you have a 180-fold reduction in susceptibility to the drug. So essentially the drug doesn't work. And that's only 5 mutations in a genome in which every mutation occurs every day. Now here's the technology. This little pill bottle is a medication monitoring system, the invention of John Urquhart, the person I've been working with recently. John is a clinician, a pharmacologist, but he's also an inventor. He likes electronics. And this pill bottle, of which there are many variants of, has a sensor in it that when you open the top, it records an event. You can put multiple sensors in. The cost of these sensors are tumbling to cents. You can either store the information, or indeed, you can even transmit it. Or you can put a GPS chip in there so you know where the pill bottle is. So there's all sorts of things. You can do it at very low cost. And you want the HIV patient to view this little pill bottle as a wonderful thing, because if you transmit the message, you can then send a text message back to say, you should be taking your pill now. You've forgotten to do so. Now, the thought of that in Africa is ridiculous, you might think. But where in the world is the fastest growing purchase of mobile phones? Africa. So text messages are a possibility. These pill bottles, there is another more sophisticated one which has a variety of sensors in the bottom. And you can only stand it up one way, and that tells you which pill you've taken out if you've got multiple pills in the bottle. Now, just to end, to illustrate the point I started on about all your behaviors, this patient here, this is a complex slide, so please ignore the detail except this little pink box. This is the time of the dose, and this is the fraction of doses taken by that patient, and this was a twice-daily dosing regime. This patient was perfect. He's the compulsive obsessive because he takes all his drugs. But when you look at his pattern of behavior, you find his interval between the 2 drug doses is totally and utterly suboptimal. So on any score of adherence, this patient would be scored as the perfect patient. But in reality, his adherence pattern is very, very imperfect. So the point I wish to make is that adherence is hugely important for a virus of HIV's kind with its evolutionary capability. If you think of Schistosome mansoni and think about its evolution, there's a lot of genetic diversity there, but its direction is like a coniferous tree with little branches going out. HIV is like a flat-topped acacia tree where evolution is going everywhere, all over the place. And so the evolution of drug resistance is inevitable, so we have to think of ways of trying to minimize that. And lastly, a very warm thanks to Joanne, Alan and Artemis, who very kindly permitted me to use some of their unpublished work. So thank you very much.
thanks very much to our speakers, and now we've got time for questions. Nigel, you had a question. There you are.
Thank you very much, Richard. Actually, I think on behalf of the Global Health Workforce Alliance, who I want to ask about the workforce issue here. Both speakers in those two fascinating presentations talked about implementation, with the last example that Roy was giving, but also with Michel talking about bottlenecks. Now, I guess that a large part of every bottleneck is having suitably trained and culturally attuned staff. In fact, the relationship between technology and staff works both ways, and having the right technology reduces the need for skilled staff, but it also works the other way. To actually get technology used, you need sufficient staff. I wonder if both speakers could just speculate on how important they see it that in Africa we get a big increase right at the beginning in trained health workers, and actually also how that would be done.
Well, thank you for raising this point. It's absolutely critical. As you said, I mentioned this as a key bottleneck. I think the amount of effort to train and the amount of people needed to be trained and the type of people that can actually, following training, deliver differs with the technologies and with the type of medicines, with prevention versus treatment versus with one disease versus the other. In Ethiopia, for example, in the last 2 years, 30,000 people, health workers, have been trained for 2 weeks to deliver malaria-impregnated, long-lasting impregnated bed nets very efficiently, which allowed for an 18 million bed nets to be distributed in 1.5 years. In going to some of the training for laboratory monitoring of HIV treatment in 6 countries in Africa, lab technicians who were sort of polyvalent lab technicians in 48 hours training could acquire the necessary skills to enumerate CD4 cells through an easy implementable technology, and after 1 year after receiving that 48 hours training, we're still delivering very reliable results, similar to those that they would deliver in the week following the training. So it's very difficult to answer in one way to the question. I think the key message is all of that is possible. You can train, you can do task shifting, and that's what we have to do rather than to wait for a generation of doctors, not only to be trained as doctors in those countries, but also to have the necessary incentives in place so that they remain in their countries rather than moving to the north.
Two thoughts, really. I do, from a long experience in the Wellcome Trust, where one was trying to train physicians and scientists from poorer countries, I really do have the impression that it's much better to try and train in Africa rather than constantly bring people out. And one of the schemes that I was involved in the Wellcome Trust at that time was the establishment of the Africa Centre, which was for demography and AIDS, where the objective in South Africa was to provide a centre staffed by a mixture of African and Western physicians and scientists, in which students from all over Africa could come to. And I personally prefer that model to bringing people out to European countries. The second issue is that we often focus on the training of physicians and scientists, and 90% of our focus should be elsewhere. It should be on teachers, healthcare workers, nurses and so forth, because for many of these simple intervention strategies, it's education that matters most. You know, why should you take your pill every day for HIV and so forth? And then the last, very last, third thought is, I was very privileged to work with Ken Warren many years ago, and Ken, before sadly he contracted a serious disease, his mission in life was to get the excitement of the web and the internet into Africa by satellite dishes, actually, he was obsessed with. Now we've got the low-cost computers now, they're down to about £40. Communication is still a little bit problematic, but you can do it by satellite. So, as you know, with our own student population, access to information on the web, you can teach yourself so many things because the volume of information. So I think we need to devote more attention to how this can be done, how bring in the communication technologists into the healthcare setting and say, how can we do this cheaply?
Would you like to say something about that?
I'm Dennis Gilhooly from the United Nations. In fact, we've been working on this area specifically. I'd like to ask Michel. Goal 8 of the Millennium Development Goals is actually for the development of a global development partnership with the information and communications technology community and the pharmaceutical community. But there's been literally zero effort in terms of interlinking those. Is that not an area that the Global Fund should be looking at in terms of moving forward? And that was a marvellous example of the possibility, I think, of RFID, GPS, or cellular in Africa. And I'm 100% on board with you. But there is one area beyond infectious, and that is on chronic. There is no Millennium Development Goal for chronic disease at the moment. And as HIV morphs into a chronic illness, isn't that the area where we should be focusing on in terms of embracing and implementing technology with pharma moving forward? Thank you.
Thank you. Well, there aren't the areas that the global, if your question is specific somehow to the with regard to the global fund funds whatever the country would request from us. We are funding country mechanisms, so we do not decide in Geneva that we would devote 60% or whatever of our funds to HIV and 10% of that for IT. We respond to the requests from the countries. Now there are a number of, there is growing interest in those in IT technologies, and there are, actually I have never heard of that sensor for adherence, but we do have large-scale implementation of use of mobile phones in Kenya to have the information come back from a laboratory to which the patient's blood would be sent, and that may be 30 or 60 miles away from where the peripheral care center where the patients had originally come would be. We have in those areas a large-scale use of mobile phones and that sort of technology to bring back the information, so that the nurse actually has the information on her mobile phone within hours as soon as the blood gets to the lab. So there is no, I mean, yes, the Global Fund does fund that type of effort, but it doesn't come from a sort of top-down decision. It comes from what is requested from the ground.
Just responding to the chronic disease end, non-infectious end, yes, of course. And the percentage morbidity and mortality due to cause from chronic is rising, particularly more in countries like India and China, which are on the faster economic growth track. But I showed the pie chart, and if you just look at that, the vast dominant part of Africa's problems is infectious at the moment. And also, being an infectious disease specialist, if in 100 years' time, I suspect most cancers will have some viral origin. So there's a prejudice statement, indeed. just coming to the adherence technology and the SIN's text message bit, first of all, I should claim I have no shares in the company, even though the person who owns it is a close friend. It is surprising to me that even the pharmaceutical industry doesn't pick up this technology for the Western world, because it is so precise. Of course, people can take the pill out of the bottle and throw it down the loo or whatever, but it's still a much better way of knowing when people have opened the pill. And it's the cost. In my previous 4 years, one of the technology advances I saw very particularly at first hand was the huge exponential change in the cost and the size of sensors going downwards. So it's these sensors now for recording very simple little things have become very cheap entities, and you only have to think of what's packed inside your mobile phone to realize that.
But what happened to DOTS and what's happening to it today? Because that was said to be a very successful program, and yet we still ended up with a lot of resistance, particularly in Africa.
First on HIV treatment. I mean, I think every technique, particularly a cheap technique, that would help adherence, I'm sure, certainly would be welcome. But when adherence is a very complex phenomenon, as you said, it could be sociological, genetic, contextual, cultural. When it comes to life-saving drugs such as HIV treatment, in fact, the experience is that indeed adherence is, if not as good, it is often better in Africa, we find, than in the north. With the MSF programs, Médecins Sans Frontières programs in South Africa, over 80% of the patients in their cohort remain on the same treatment after 4.5 years.
Yes.
With 85% of those having undetectable viral loads. Whereas, if I'm not wrong, that's a paper about 6 or 7 years ago published by the Royal Free cohort. About 40% of the patients taking antiretroviral combination therapy would change at least one drug in their regimen within the first year of treatment. Mm-hmm. So the contexts are very different. DOTS, if your question refers to TB now, or to DOTS in HIV, because DOTS is hardly used in HIV except in some prison settings or very specific settings. DOTS is the recommended technique to deliver TB treatment, and the recommended technique to actually prevent the occurrence of resistance by making sure that the treatment is taken with the right drugs at the right time and for the right duration of time. The world hasn't yet reached the goal of 85% cure of TB in the developing world. But DOTS remain the standard and the recommended technique. If resistance is spreading in a number of regions, in Southern Africa, maybe in other places, but we just don't know because we don't monitor it, or in regions like Central Europe, or Eastern Europe, Russia particularly, it is in contexts where the treatment has been inadequately taken, and that's in most cases because actually DOTS have not been effectively implemented.
Okay, Rita?
Actually, my question follows on very nicely from this last discussion. And we've been doing a lot of work around DOTS implementation in Russia and Eastern Europe. And Michel, you mentioned South-North learning. We always refer to North-South learning. Europe now has the fastest growing incidence of HIV and also MDR-TB. And we're not going to reach MDG goals in Europe because of poor uptake of DOTS, particularly in Russia and Ukraine. And you mentioned health systems as being a constraint, but most of these constraints were resource constraints. In Russia and Ukraine, there are no resource constraints, yet the health systems have not been able to respond to the epidemics of HIV and MDR-TB. So what lessons can we learn from Africa?
I'm not sure I would learn lessons here from Africa, and of course what I presented and what I discussed was to answer the invitation of reflecting on reaching the MDGs in Africa. I fully take your point and agree with you that Eastern Europe and Russia is currently the fastest growing region with regard to both HIV and resistant TB. And the answer there is not the lack of health systems, obviously. It is the fact that it is a disease of vulnerable, marginalized populations. That's where it starts, and that these populations do not have access neither to health nor to social services. So with regard to HIV, as you know, of course, the epidemic has started in IV drug users. It is still a concentrated epidemic. It's spreading to, it's becoming more and more, the feminization is increasing, yet it's still a concentrated epidemic, fast-growing epidemic in IV drug users that are still considered as delinquents and are not considered as patients and not at all considered in the public health perspective. The same is true for TB that has spread particularly among prisoners in confined environment and populations that the government in the last 15 years have neglected and marginalized. So the issue is very different. It is a social and political issue rather than a health systems issue.
Totally agree.
Thanks. In this depressing discussion about the inevitability of emergence of drug resistance, I'm wondering whether the speakers could reflect on what sort of strategies we should have for developing new technologies. It seems to me there are two ways we can go. As Roy knows, as you increase selective pressure, you increase the relative advantage of a resistant organism. But if you increase selective pressure enough, you can drive it to extinction. So that would be one strategy, trying to improve our technologies to actually really drive the organisms like HIV to extinction in individuals and in populations. The other is an arms race in terms of developing new technologies to deal with the resistant organisms. And as Roy said, the HIV can evolve in a period of days, but actually for the epidemic of resistant virus to spread is going to be on the same time scale as the initial HIV epidemic, which does give us some time to respond with new technologies. I wonder if the speakers could reflect on that.
Sort of multiple thoughts, actually, Jeff. You know this well, that with HIV, to apply sufficient selective pressure to drive to extinction, I think is very difficult. I think with schistosomes, because of the long generation time, it's a totally different ball court, and one could probably do things there with enough will and drug delivery that you couldn't for HIV. The history of all treatments in infectious disease, and I include everything here, is that it's a natural part of Darwin's selection, natural selection, which is if you apply selective pressure hard enough, you will evolve resistance. So you're quite correct to ask the question, what technologies? Now, evolutionary theory tells you that to evolve, to retain genetic diversity, you've clearly got to have a resistant phenotype which, in the absence of drug selective pressure, is as fit as the wild type, because when you relax the pressure, it's going to dominate. You want to keep the selective pressure broad. So in HIV and with TB, and sadly, malaria may learn this lesson soon, since the major new drug is having problems in parts of Africa, you need to have a variety of modes of action of the combination, targeting different genes, different parts of the biology of that organism. The slight worry with praziquantel, of course, is that you've only got one effective drug there. You still don't quite understand its mode of action. And are you targeting a particular part where evolution could occur on a longer time scale? So the answer, I think, is to keep the selective pressure broad and varied constantly. And I think history supports that, and combination drug pressure supports that. The only slight downside, which I think Richard is much more qualified to comment on to me, if you look at the rate of discovery of drugs for, and this not only applies for infection, then there is a steady decline in the rate of discovery of new compounds. There's been no new antibiotic of a significant new target. The HIV area has run into a couple of problems recently, with new targets looking interesting and then failing. And somehow, because, of course, for the pharmaceutical industry, Africa is not a profitable environment. But to deal with your problem, we've got to have a pipeline of new HIV drugs coming through, which can be included as part of the combination. And to do that, we've got to keep the pharmaceutical industry interested.
Yes, I was actually going to comment along very similar lines on the fact that when it comes to HIV, the relationship between genotype, phenotype, resistance sensitivity, fitness is extremely complex, so that we can't really easily predict what will happen in a population basis. So this is why, indeed, having the broadest umbrella possible in terms of treatment is the strategy to have. With regard to the pipeline, I'll turn it to Richard also. At this time, for HIV, there are a few concerns, but there are also positive signs. I mean, 2 years ago or 3 years ago, we started with fusion inhibitors, a new class of antiviral drugs. This year, we have now on the market integrase inhibitors. So far, the industry has been providing one after the other a new class of drugs, but there are limits probably to what will be available, and since the target of these drugs is a protein, we will inevitably run into resistance problems at length. So the eradication will have to, regimen will be the one solution that we look for. Whether that will be achievable with a combination of drugs or with drugs plus immunotherapy or whatever, I don't know. But until then, we'll just have to sort of go after the virus and try and prevent resistance by having the broadest possible spectrum of drugs.
But the problem is the genome's so small, you've only got so many targets anyway, so you're going to run out of those targets.
Right.
So the next thing, of course, has got to be the vaccine. Maybe that's what Jonathan's going to come on now.
No, I have a different question for Michel, and it's about the future of the Global Fund. The success of antiretroviral rollout in South Africa has been absolutely stunning. There are more people on antiretrovirals now around Durban than in the entire UK. I think probably more in the South Africa than in the whole of Europe. And the success of that throws into really stark relief our failure, or their failure, to get to grips with chronic disease has been mentioned. Antihypertensives, there's no program, insulin is very sparsely available, there's no thyroxine and so on. Do you imagine that the Global Fund will become ultimately not a vertical but a horizontal program? Is this the direction it will move?
This is a tough question, and Jonathan, and it's been the issue from the very beginning of the Global Fund. This is something that I actually discussed with some of your colleagues, Roy, in Ouagadougou 5 days ago, about neglected diseases that could somehow easily be added to the scope of things that we're funding. In 2001, actually, I was at that time, a member of the French delegation of the group that discussed about the Global Fund. And we spent 2-3 months discussing whether it should be a global fund for health, or a global fund for infectious diseases, or a global fund for neglected diseases, or a global fund for HIV, because Kofi Annan had actually originally called for what he called a war chest for AIDS, or a global fund for HIV, AIDS, TB, and malaria, which is finally what the result of that choice. I thought at that time that choice was very reasonable, because what Peter Piot would call the exceptionality of AIDS is something that is difficult to sustain in terms of advocacy, particularly when you see the impact that malaria treatment can have on morbidity or prevention on morbidity and mortality, and when you realize how easy it is to implement DOTS and have people cured from TB, or how easy it is, and it could be, to deworm a number of people with some of these neglected diseases. So the exceptionality of AIDS is difficult to sustain. On the other hand, it's AIDS that really has mobilized not only the political world, but the society, the civil society, the advocacy. So by having AIDS, TB, and malaria, you could address the three main killer diseases of the developing world. You could broaden the scope beyond AIDS, but you would still have AIDS somehow as the pilot for advocacy. 5 years later, it strikes me in my current position as director of the Global Fund, or even in my former position as the HIV/AIDS ambassador for France, as I meet with political leaders, as I work to prepare for the G8. It's really striking to see how AIDS, TB, and malaria mobilize the political world, and how the rest of the diseases is totally out of the radar screen. So I think it would be very difficult to change the scope of the Global Fund, not only for it to become a horizontal fund, but then even to be or to become a horizontal fund, and actually or to be a fund that would allow for what you call the epidemiological transition to the chronic diseases that you were mentioning. I think that's the role of the countries themselves. I mean, the Global Fund is there to impact on these three diseases, and let's not forget that we expect the countries to increase their health budgets. African ministers of health committed to go to 15% of their budgets for health in Abuja in 2001. And a number of these countries have a fairly substantial economic growth. I hope India, China, will be able to devote part of its growth not only to defense or sending satellites to the moon, but also devote it to health. And I'm not sure we should go on funding them heavily as we do with the Global Fund. Our portfolio in China is $450 million. I would rather invest some of that money in Africa, which, by the way, is also experiencing a relative good economic growth, at least for some countries. So going from where we are to where you would like us to be, I think really would involve a large share from the country's efforts, rather than keeping it coming from donors.
Okay, right.
And just two quick thoughts, really. The $450 million for HIV and AIDS in China, I very much agree with you. I hope that's a transient, given the actual economic performance of the country. It could well afford to do that. The second issue, though, is in slight disagreement. It is many times in life, particularly in research, I think you take opportunities where they lie. I'm not an optimist for the HIV vaccine in the near term. I'm really not, for a variety of reasons. The malaria vaccine, more optimistic because of recent developments by two companies. But I think with the neglected tropical diseases, it would help to have the imprimatur of the Global Fund. But you could find ways. I see a lot of interest in the city and the banking sector, and particularly in Switzerland too, as well as London and New York, Well, I think one could raise the 1.5 billion, but it would help to have the imprimatur. And so that's the comment.
Right. In answering Jonathan, I wasn't saying that we should go on neglecting the neglected diseases, right? I was saying I just don't see the global fund the healthcare necessary for the epidemiologic transition that is occurring slowly in these countries. With regard to neglected diseases, let's talk about it further, but I see no reason. I mean, a lot of the logistics that we are funding in countries could be used as logistics to deliver those drugs. So.
Much easier to deliver. Steve.
Drinks.
It remains for me on our behalf to thank our two speakers this evening, Michel and Roy, for providing two spectacular talks of such immense complexity. I think we all know, but have had ample further evidence tonight, that healthcare in Africa is a huge and complex topic, and that it will take a combined efforts of many, many different competencies and skills. Adherence for a start, Roy. I was reflecting on the fact that the title of our talk this evening was "What can medical technology contribute to the attainment of the Millennium Goals in Africa?" And whilst the development of retrovirals and HIV therapy has been, in many respects, a great success story, I think the message that both of you have given is that a lot of this is actually about human behaviour, social behaviour, and actually financial and economic behaviour. And I think your point, Michel, of how health has changed, the conceptual view of health, that you need that health follow just economic development, as opposed to health actually being required for effective economic development. It just shows that the social and political implications of the work in which you are both heavily engaged. So I think it is a great reassurance for all of us that these major problems, which in many respects will rebound anyway into the north, are now achieving the world significance which they do. It is, of course, the 100th year of Imperial College, and I think one of the issues is that the college was established to have practical effects on humans. And I think, Roy, your exposition of the schistosomiasis program, it's difficult to see a more obvious direct effect on the quality of life of individuals wherever they live, which I think is another important message that I'm sure our government would be keen to hear. This is one of the last of the lectures of the centenary year, and it's difficult to imagine that we could have gone out on a greater high. I would like to thank GE Healthcare for sponsoring this lecture and for its ongoing support for the work here at Imperial College. And particularly I'd like to thank all of you for attending this lecture here this evening. You're all invited to join us for a drink in the reception in the foyer of the building after this. But before then, I would like us all to thank the two speakers, to thank them in a normal fashion.
You've been listening to a special lecture vodcast from Imperial College London.